Well, good morning, everybody. I think we'll get started. It's 8 o'clock. It's nice to see you all here this morning on this sort of chilly fall day. I'm really excited about our speaker this morning. Dr. Xiaoyan Huang is a cardiologist and the medical director of clinical transformation at Providence Heart Institute, as well as the medical director of the Providence Heart Clinic East, and the president of medical staff at Providence Milwaukee Hospital. She sits on the board of the Portland Inter-Hospital Physicians Association. Dr. Huang graduated from Yale College and Stanford Medical School, and then did her internal medicine residency and cardiology fellowship at OHSU. She also has a master's degree in healthcare management from the Harvard School of Public Health. And in addition to her clinical practice, her research work has focused on specialty practice improvement, payment reform, health policy, and economics. She's published on these topics in the New England Journal of Medicine, Harvard Business Review, New England Journal of Medicine, Catalyst, Circulation, and I became excited to have her speak to us after reading her front page article in the New England Journal Catalyst in May of this year. The patient-centered specialty practice is sort of a mirror of the patient-centered medical home that we have in primary care. And I believe Dr. Huang is the first to publish in this report about implementing this model in a cardiology practice. And she did so right here in East Portland. So we're thrilled to have you and welcome. And Dr. Huang.
Good morning. Thank you, Dr. Powell, for inviting me and for your introduction. As I stand behind this podium, over the years, I can visualize kind of a two divergent age curve. As my age grow exponentially, or at least it feels that way, higher, the person who introduced me, the age goes down. So I had I had Dr. Warnke, we miss him, and then Dr. Liz Stevens, who's my contemporary and friend, and then now we have Jesse, who I still think of as an intern. But did I just pull a Joe Biden on you? I think you can hashtag me too right back at me. Thank you for being here. I know this is not a clinical topic that usually medical grand rounds are for, but while I have you for the next hour, I hope to convince you that this is a topic that we all need to care about, whether you are a specialist or a primary care, whether you're a doctor or APP, a CVL tech, a nurse, an administrator. This is our profession. We need to care about it. And God forbid, we at some point will all be a patient in this neighborhood. And for that reason, we should all care about how care is delivered, not just what care is delivered. I also want to take the opportunity to introduce a couple people here. Jennifer Zelensky is our new COO for the clinical programs. Before that, she was our chief executive for Providence Heart, and she has led this program from the beginning, from day one. And then we also have Leslie Jones-Larson, who's my partner in crime, who's the director of operations, without whom none of this work would have been possible. And also we have other of our team members here too. So I don't have any conflict of interest to disclose. My interests are completely aligned with this presentation. I talked about, I want to convince you why you need to care about what I'm talking about today, and then also reflect a little bit on Medical Neighborhood 1.0, which is really the infrastructure of how medical neighborhoods are built, and then go on to describe what is the contemporary version of medical neighborhood. So if you're a medical student like I was and you Googled what medical neighborhood 2.0 is, there is no such thing. I coined the phrase for this talk, and I hope to be writing about this, so nobody beats me to that, okay? And then I'm also going to use our story, our journey, to talk about the 4 key success factors we think a medical neighborhood 2.0 should have. So why should you care? So earlier, that exercise about age is not just to brag how old I am, but rather to lead me to the opportunity to reflect what I have seen in my practice as a cardiologist over the last 16 years. So when I started with the Oregon Clinic practicing in this hospital in 2003, FDA approved the first 2 drug-eluting stents. So since then, even though we all know, all of us know that stents do not result in mortality benefit, we're still putting them in every day, every hour probably. So globally, stents are over $8 billion market a year. Does anybody know who this gentleman is? He has ruined many cardiology fellows' call nights, and this is not a Me Too story. Dr. Murphy, do you know who this is? He has become the bane of every cardiologist's lives. He invented the troponin assay. This is Hugo Catus, a German cardiologist. Beta blockers. Who remembers the times when beta blockers was the no-no villain and never to be used in congestive heart failure? And during my training, beta blockers with these 4 trials became the heroes of congestive heart failure therapy with an astonishing 35% mortality benefit. In a slightly tangential vein, LVAD we also use, and we continue to use to keep villains and heroes alive as bridge to transplant. I don't know if this needs to be bleeped out in the recording. So this is the Edwards ad for TAVR. Who would know within the last 10 years, TAVR has become our saver. Get that? Saver? S-A-V-R. These things cost over $100,000 over the first 2 years of care. And we're putting them into people left and right. Yesterday, I had a patient who had a TAVR who's done very well, and he said, my friends told me I have this fancy new valve in and I should feel much better, but I don't. So to my interventional colleagues, if I'm 90 years old, I need a TAVR, don't give me that, give me the money. And buy me a one-way ticket to the Caribbean, and with that price, a private jet too, right? So I'm just being trying to be funny, right? One of the things I like to do on the side is to try to dispel the myth that Asian women cannot be funny. So, but in reality, I am not this cynical nor a hypocrite, because I do practice. This is what I practice every day, is clinical cardiology, referring people to LVAD, referring people to TAVR. But at night, because I grew up in China and I look at this health system in America, which is the world's most expensive system and certainly not the best in quality, as an outsider. So I think about other issues too. For example, cardiovascular disease, despite all that we do and do so well, the disease burden remains very high. So the blue line, you do see that the old age mortality for cardiovascular disease has been decreasing, although we reached a nadir in 2010, and now it's gradually creeping up again. In the country where I come from, in China, over the last 30 years, the disease burden has been steadily climbing. Cardiovascular disease remains the leading cause of death in the US. So the red line is very reassuring, right? The percentage of relative cause of mortality from a cardiovascular standpoint is decreasing, probably because of the great stents, the TAVR, the LVAD that we're putting in. But unfortunately, the green line is rising, which represents cause of death as dementia. So we may have a beautiful heart, but we're just not able to remember that. Cardiovascular disease remains the leading cause of expenditure amongst all disease systems, higher than orthopedics, endocrinology, or mental illness. The only, and all those disease systems, the cost of care is rising over the last 16 years, except GI. I'm not sure what they're doing right there, but I did plot this, their curve in the color of melena. I hope you appreciated that. So if you say, I don't really care about global health, I don't care about cost of care, you probably care about your patients and how they're feeling about our health system, right? So I don't know how many times I've been to a dinner party or even that I host the party when invariably the conversation goes into doctor bashing or complaining about health system, despite the fact that I'm sitting right there, right? I fed them dinner. But they have their points, right? Access remains poor. For a patient to see me for a 20-minute appointment, we're booking out into January. We don't have open scheduling, right? Jennifer or Leslie, can't we hire Open Table instead of Epic, right? You can schedule, you can change, you can cancel on Open Table, and yet in Epic, the schedulers have to pull up our individual schedule to see do we have an opening and make all these calls. And then I know some of my colleagues are here, so I'm not going to show the screenshots of their Epic in basket because some of us have hundreds of unanswered calls and messages and test results that are not followed up. So those are not only patient satisfaction issues, but also patient safety issues, right? And then lack of price transparency and billing is a mess. Even for me, I don't understand. I got some bill for physical therapy sessions I've done. And it's some, in my chart message, it says these are payments are due. And then I get paper copies that says this is not a bill. And then I call them and they say, oh no, we billed your husband's insurance already. So it's a mess. And then lack of communication. So until we started doing this work together, and Kathleen knows this, we couldn't find where as specialists, we couldn't find where the referral notes are, even though you as primary care doctors, providers, write beautiful notes telling me why I'm seeing this patient, why you're sending me this patient. It was buried way to the right, way low in Epic. So I used to open my visit with a patient saying, smartly, I thought, so what is the reason that you're seeing me? Now I realize from the patient standpoint, I must sound so stupid, right? They assume that we are talking to each other and we know exactly what's going on and all the data is in the computer and we have nowhere to find them. So, so payment is changing. If you don't care about the global cost, you don't care about your patients, at least you should care about your children's tuition bill, right? So this slide is very busy, and I don't want you to read it. I don't. My son helped me with editing this slide deck, and he said, "Mom, that's terrible." Indeed, this slide is here to show you, to remind us how complex payment is. And I know whenever I talk about payment to my clinical colleagues, their eyes glaze over, they start reaching for their phone. So I'm going to give you a 2-minute synopsis about payment in a very simple-minded way. So fee-for-service, think of it as a la carte. You go to a restaurant, you order something, you pay for that item. And in this analogy, we are the restaurant. We deliver food or care, and our patients are the consumers. So on the other extreme is a global care. So that's probably usually a closed system. I used to use the analogy of a buffet, and I say, that's the payment model for Kaiser, but I realized there's a very negative connotation with that. So I'm going to say this is like a meal plan for your college kids that you pay very expensively for, right? You pay for the year, and they eat whatever is offered. So in between that is probably what we will always have to deliver to in an open system like Providence. So some of our patients will come up to us and they'll pay fee for service. And some more and more, Medicare is saying that in the next 5 years, 70% of our payment will be value-based, meaning that that the payment will be linked to some sort of quality metric. So what does that mean? In a restaurant, it means it's like a prefix menu or a set menu, so that you pay a price, you get 3 courses. Maybe that includes the drink, maybe not. So in that analogy, we as a specialist are the bartenders, okay? So we used to be the favorite child of the restaurant, because the more drinks we sell, the more money the restaurant will make. However, in this value-based, maybe sub-cap or full capitation type of model, we are the liability to an insurance company. Or maybe some of the payment will be going to primary care clinics, so we become a liability. The more we do, the more TAVRs we put in, the more we are a cost to that global payment. So how do we maintain our professional lives? How we need to deliver value to that program. So hopefully I've convinced you with all that you need to care about what we do and how we deliver care and how we provide value to the payers, to our patients, as well as to our referring providers or practices. So what is Medical Neighborhood 1.0? So Dr. Elliot Fisher is really regarded as the father of Medical Neighborhood 1.0, and I hope to be the mother of Medical Neighborhood 2.0, but that never seemed to happen. So what that concept is really the neighborhood is built upon medical home, which is the primary care clinic, and that this work has defined, developed, and really set a role model for the specialty groups as how do you provide team-based care, and how do you provide whole patient and patient-centered care. Of course, the patients don't like patient-centered, because my friends always ask me, so patient-centered, that's a new thing? What was it before? Medical Neighborhood 1.0, the work has resulted in a recognition that primary care's work cannot only be measured by the the patient encounter. There are a lot of things that you guys do around care coordination that was not previously paid for, and now it is. So that has been a triumph for medicine. But since then, what has happened over the last 10 years? So that brings us to Medical Neighborhood 2.0. And I'm going to start telling our story and our journey starting in 2013 when the NCQA, which is the National Committee on Quality Assurance, and that's the certifying body that certifies health insurance companies, hospital programs, and patient-centered medical home for primary care. And then in 2013, they developed a new set of standards or the blueprint for how patient-centered specialty practice should be. So Providence Heart Clinic was one of the 64 early adopters in the country. And I remember it was on my birthday in 2013, Jennifer, Leslie, and I spent a whole day working and learning from NCQA what this set of standards are and how we can implement that in our group. And indeed, we took that blueprint and look at what we did and learned and developed new workflows on the things that we weren't doing. And then in a year, in 2014, Providence Heart Clinic at Gateway became the first cardiology clinic in the country to become recognized by NCQA as a patient-centered specialty practice. And then over the next 2 years, we spread our best practice across all of the cardiology clinics in Oregon for Providence. And it was helpful as that was also the time that we were merging different groups of cardiology practices into Providence Heart Institute, Providence Heart Clinic, and we use the national published standard to spread best practices so that it wasn't, the west side should do what the east side did, or the east side should take up what the west side is doing. So this also helped brought us together. So in 2013, all of our cardiology clinics in the state became level 2 certified or recognized. And even if today, when you look up on the NCQA website, you'll see that the Providence Heart Clinics are the only cardiology clinics in Oregon that are so certified. And currently, Leslie and I are working on our third iteration and aiming to achieve level 3 NCQA recognition again for all of our clinics. So importantly, I talked about how important it is to have strong leadership. So we have Jennifer working with us, empowering us, and giving us the support so that we can do this work from day one. And it's also important to know that we were smart and we were not reckless. So we took the national standards to guide our work, but we also had our own vision. So in 2014, we published this New England Journal Perspective highlighting the importance of specialty practice transformation in this newer version of patient-centered medical neighborhood. So that's lesson number 1, is you need to have strong leadership that guides you and empowers you throughout this journey, and you need to have vision to know where you're going. And then you can take the national standards and use that to guide the step-by-step concrete work that you do. So in the next 3 slides, I'm going to share some of the data that's been published in the article that Jesse mentioned. And I'm going to give you a few vignettes about how we did this. So the first graph is on the right. You see all the results there. The graphs are a little bit small. We So we published our data from 2013 till 16, and we showed over those 4 years, we improved new patient access so that the new patient seen per physician clinic hour increased by 25%. And that was not at the compromise of our follow-up patients. So how did we do this? You need to recognize this is very important because our doctors are not paid by the number of patients seen. We share our compensation, we work equally. So this highlights the importance of creating a corporation or company or group culture, which is that money doesn't drive everything, that we as physicians, as APPs, we have our intrinsic motivation, which is to better take care of our patients and to think in long term and grow our business. And also throughout this time was also the time when we joined together previously two big competing groups from the east and west side of the river. And we also started using Epic. So these were challenging times, but we kept reminding our providers to not take on this self-victimization or this learned helplessness, right? It's Providence fault, it's Epic's fault. My life is terrible, I hate this. Rather, this is our lives, this is our profession, and let's make it better. So the second success factor we found is that you need to create a culture of leading change rather than being led or letting change happen to you. The next story is our success is around improving patient satisfaction through this work, particularly in panel C. You'll see we achieved significant improvement in test result reporting, and that is one of the key things that we work together, and we continue to work together now with our primary care colleagues. So we pay attention to details such as in Epic, what is the best way when you get a test result back? Who is responsible? How do you document that? How do you communicate that back to the patients? And how do you communicate that with the referring doctor? What is the most efficient, fewest clicks, and yet convey the information so that other people, when they're looking at the chart, they know you've handled this test results. And this is still a work in progress. Kathleen knows this, and we bring teams together from executives to frontline providers to IT to scheduling to referral team to high-level Epic people. So the lesson we've learned is that you need to leverage the power of technology. Technology is our friend. Epic is here to stay, so we better make it better. We better make this tool work for us. I know you have been away from your cell phone for about 29 minutes. You're probably all going into withdrawal. So I'm gonna have a commercial break and ask you to take out your cell phones and download our app, Providence Heart Now. So this should be a very useful tool, particularly for those of you who are outside Providence independent providers. So the logo looks like this. It's called Providence Heart Now. And the app shows you our subspecialty, who are the specialists doing what things. You have our directory and our heavily photoshopped pictures with all beautiful skin, everyone. And then you have a one-touch phone number. Please don't call that because right now it's all going to Leslie. No? Oh, okay, it's real. So you can call that number so that you know who, how to get around our big system. And then we also created some care resources, which are clinical pathways. So currently we only have three. One is for emergent shock for probably more of our hospitals colleagues. If you have someone with cardiogenic shock, what is the workflow, who to call, and how to arrange for the transfer. And then for the non-emergent clinical pathways, so far we have two, AFib or a flutter or a chest pain, what test to order when. So I'm responsible for the chest pain pathway. It is a PDF, and that you can download that, you can put it on your desktop, you can even print it out. And I also put the EPIC order number for the appropriate test in there for you. And we hope to get your input as to what other clinical pathways you may find useful, and we'll continue to develop those and put those in this app. So back to regular programming. Put your phone down now. No more Facebook. So the next set of slides talks about how we've improved our productivity and efficiency. We've increased our clinical growth. These are like the dream story for execs, the C-suite people, right? We've increased our number of encounters per physician FTE by 25%. We've increased our gross revenue for the group. We've increased the complexity of the patients that we see. And at the same time, we've decreased the cost of clinic cost of RVU production. So how did we do this? So one example is the closer role. In the past, when after I see a patient, I would type their after visit summary, and I hit print, and then I come out of the room, go to the printer, take that AVS, go back into the room, and go over the same set of instructions. I just talk to the patient one more time, and then I wait for them to slowly get up from their chair and then walk out of the room, and I want to walk them down the right hallway so that they can go to scheduling. And that takes minutes of my time per patient. Now we have this closer role, either with an RN or an MA. They are sitting by the printer, and in between patients, they're answering phone calls, doing desk in-basket work. But when that printer prints the AVS, they'll take that, they'll go back into the room, they'll explain to the patients what I wanted and direct them to the right place. So that helps the patients by going over one more time the instructions. It helps reducing the number of unnecessary callbacks because patients are less confused about what they need to do. And it saves my time because now I can go back to my room and work on the documentation. So that was just one example of the kind of work we've done to improve our productivity and efficiency. So the last lesson is applying design thinking and critical making to what we do. So what is design thinking, right? You take a problem, you come up with potential solution as a designer, or you take a potential solution that somebody else developed. But if you don't, and then you implement that, but if you just do that mindlessly and without further improvement, it may or may not work. So we need to also apply critical making in this process, which means we do something, we put something in place, a new workflow, and we see if it works or not. And we empower the entire team, from the docs to the APPs to the staff, to figure out, is this working, is this not? Why is that doctor not learning how to use my chart message? Why are we still changing that into a phone note? And that invariably creates more back and forth messaging. How can we teach that doc to learn these new tricks? So that's what we do every day in our group, which is this design thinking and critical making. So in summary, we think that we have the most critical ingredients to create a successful medical neighborhood 2.0. And we're happy and we're proud that for a clinical program, we are able to get our work out there. Leslie and I have been invited to speak nationally, to teach courses, and other people are coming to us to learn from us. And and nobody else is doing this work, really. So we're proud, and we're putting our Providence name out there, and we're continuing that work both internally with PMG primary care as well as with other referral clinics such as Dr. Hirsch's Broadway Clinic. Thank you for your work with us in collaboration, and Northwest Primary Care, Pacific Medical Group, and Portland Clinic. So, but that is not everything. We saw, so you can think of us as a startup company. We had our rapid growth phase. We did great, and now we're in our sustainability phase. So in our most recent provider survey, we got lots of positive feedbacks. Our scores were higher compared to other Providence groups. Around all of these things that I just said, we're proud of the work that we do. We have confidence that my clinic will be successful in the coming years. We provide safe, high quality work, and there's a climate of trust in my group. So these are all great things. That means our docs are aligned with what we're doing. But we have a problem, which is we have burnout, right? They're saying, a lot of them, 60%, 50% of us are saying, I can't enjoy my personal time without focusing on work matters. I'm not able to free my mind from work when I'm away from it. I'm not able to disconnect from work communications during my free time, emails and phones, where Leslie and I probably scored very low on this. I rarely lose sleep over work issues. I'm satisfied with efficiency of patient flow in my group, so we can still improve. So this highlights the importance of provider wellness, which is a new focus that we're working on this year, is alongside of all the work we do to improve efficiency, how can we pay attention to the people who are providing care? So in summary, we believe the medical neighborhood 2.0 has the following important, must have the following important features. So infrastructure-wise, we believe the neighborhood still should be centered around patient-centered medical home, the primary care providers and clinics. And then surrounding that, there will be hospitals, long-term care, specialty practices, and we all have to work together and work together well to deliver this care and to be paid appropriately for the work that we do. And then culturally, we need to have leadership and vision. We need to develop and foster a culture of leading change. And we need to be able to leverage the power of technology, and we should apply design thinking and critical making to everything that we do. So I want to thank our team. Many of you are here. Maybe you can stand up if I mention your name. Leslie Jones-Larson, Hannah Berg, Danielle Christensen, don't be shy, Kara Rep, Kateri Spinelli, I don't see you, Lian Wang. These are the people who helped us write our paper. We have our academic advisor from the Harvard School of Public Health, Dr. Rosenthal, and then Jennifer Zelensky. And then, of course, all of our providers. I see some of our APPs and docs here, so thank you very much. So we can finish early, or I'm happy to entertain any questions. Charles. Oh, both Charles? Go ahead. Okay, go ahead.
stable patients, thinking of our model of psychiatry care, which is not perfect, but it's a short-term intervention, stabilization, turn back sometimes too early from our standpoint, but to primary care. So that could be a big a bonus for the neighborhood as well. Have you spent some time analyzing that?
Absolutely. So we have smart phrases when patients are stable to say, I say, dot, return to PCP. So I say, Dr. So-and-so, this patient is stable from a cardiology standpoint. I return his or her care back to you. Future refills will go back to you. If you have any questions, please feel free to send the patient back to us. So that has, eliminated a lot of unnecessary stable patients that we have been holding on to. Charles, do you have a question?
Well, first of all, Shannon, congratulations on that one talk and on what you've done here. Started this all yourself, which is amazing. The last slide of the provider feedback on burnout.
Yeah,
This one.
yeah.
So there's nothing that, to compare that to, like what was it like 5 years ago, 10 years ago? Do you think these poor or rather worrisome results on the provider survey is as in part as a result of the increased efficiency?
Well, yeah, I mean, I wouldn't say it as a result of the increased efficiency per se, or I think you mean, I would put it increased workload simply, right? So no, we don't have all their provider survey results, but these will be put out serially so that we can compare over time.
Charles, these are actually an improvement. We do have previous survey results. It's pretty significant.
Oh, so this is an improvement?
Yeah, she has a previous slide where it shows 4.5, et cetera.
That's good.
So these are the positive, yeah. I think we have 1 or 2 previous, yeah. Any other questions? Have I convinced you that this is important? No? Maybe? Okay.
I had another question. I learned this morning on the radio coming in that this is National PA Week. And,
Yeah.
could you comment on the impact of that on your transformation? Because it seems like there's a lot of PAs working for the cardiology group right now.
Yeah, PAs and NPs, they've changed our lives for the better, for sure, right? Jane and Cindy, they work together with us on the inpatient service, so allowing us to not have so many physician manpower in the hospital, so that we can be more in the office. In the office, they help take care of stable patients, so that we can be more available for the new patient. That's certainly is a key factor of why we're able to see more new patients and more patients in general, for sure. Thank you for every day. Yeah, go ahead.
So an interesting thing happened in 2013, and that was when the Oregon Clinic Cardiology became Providence Cardiology. Within about a month, my ability as an intern who's taking care of complex medical patients to call cardiologists, specifically the individual's cardiologist, and talk to him about an incipient problem went away. And it created a pretty significant challenge for me to use Providence Cardiology, because the phone, which used to be my friend, no longer worked. So my question is, how do you suggest primary care internists communicate with cardiologists when we have a problem, rather than just sending the patient to?
Yeah, so this is our phone number, and we're hoping that this app will help you. We recognize that it is difficult, and in medicine, it's not just us. In hospitalists, we become kind of shift workers, right? We are not following our own patients and rounding on our own patients when they're admitted. We are on service or off or in clinic. So that is a problem, and we have to adjust to that. There are different technological ways to connect with us. If you're on Epic, you can have the secure chat, and that sends the patient chart to me, sends a message to me. We hope this one phone number will help people. If you're inside Providence, there's link that you can reach me. You can send me e-consults, which is, if you have a question, you don't know if you want to refer the patient, if you want to help decide what's the right first test to do. That has worked really well with PMG referring doctors. We hope to be able to get that set up to outside referrals. Yeah, we've developed care agreements with all of our major primary care groups so that we can define, who is doing what and what is the best way to communicate. I don't know, how did you used to talk to the individual cardiologist? You called our main number and asked for that person?
Yes, and they would either get on the line or they'd call me back in a timely fashion.
I mean, I think,
I have found a way to go around this because I have a couple of your group who I have their cell phones, so I text them, but that works.
yeah.
For the most part, it's been very difficult to communicate. I didn't have this number, so.
Yeah, we've always had a backline, but we recognize indeed it is more difficult. I think as individual physicians, we're always happy to take your calls, and we need to do better.
I know that this is such impressive stuff. Do you, after you see a consultation, call the referring physician?
No, we don't have that kind of time. And I don't know if the referring doctors want me to be calling them either. Do you?
No.
See, that's my life, Yeah. Exactly. Right. That's how we communicate. Yeah.
Does your, what we'll call burnout, does that break down by age in any way?
I'm not sure if we have that kind of data. Yeah.
Younger people are more or less satisfied.
That's hard to say. Yeah. Great. Thank you very much.